Thank you so much, Peter, and good afternoon, everyone. Welcome. Glad to have you here joining us for the University of Maryland Medical System's Let's Talk About Health. It's a community conversation series that we do once a month. I will moderate this program today. Let's Talk About Health is designed to do a few important things. Number one, increase awareness about key health topics that as we bring them to you on a monthly basis. Provide people with tools to help them stay safe and healthy or to help maintain the health of your loved ones. And then thirdly, to improve discussions between you, community members, or and with your medical providers. Today's topic, as you know, is sudden cardiac arrest. And I think I'll say first that while the term sudden cardiac arrest and heart attack are used interchangeably, they're not the same thing. So we'll talk about that today. And here to present today, I'm glad to have Dr. Jeremy Pollack. He's the Director of Heart Failure and Cardiac Population Health Cardiologist at the University of Maryland, St. Joseph's Hospital in Towson. I'm proud to say he's a Baltimore native, and he completed his medical school training at the University of Maryland School of Medicine. We can go to the next slide. Following that training, he had a medical internship and did his residency as well at the University of at Vanderbilt University in Tennessee. He then came back to Baltimore and completed a cardiac fellowship again at the University of Maryland. Dr. Pollack is board certified in 4 areas: internal medicine, general cardiology, echocardiography, and nuclear medicine. He's been a member of the medical staff at St. Joseph's since 2017, and he specializes in preventive cardiology, cardiac imaging, and heart failure. I'm really, really pleased that he's able to join us today. Before we get started, a few housekeeping notes I want to share. Please, as Peter said, feel free to type your questions in the question and answer box, and Dr. Pollack will be happy to answer as many questions as he can. I would note for you that we will not be able to do individual diagnoses or answer questions that are really, truly individually based, but I'll be happy to answer questions that are of a more general nature. And again, this conversation is being recorded. I'll share more information with you later about how you can get the recording, as well as how you can see the slides again. And so it'll be available in a few days. I want to also note that in this series, we usually talk about the Ask Me 3 model. We're not going to address that specifically, but I want to mention for you again what that is. For those of you who've been here before, you've heard that. We suggest that you think about 3 questions when you're speaking to a medical provider. If you have something that's troubling you, you want to be sure to ask the simple question, what is my problem? Get a definition of what that may be and have it named for you. You want to ask, what do I do about it? What are the recommendations that your provider would make for you? And then finally, why is it important that you do what is recommended? And we say that all of those things really work very well in providing you sort of a bucket where you can place all of the information and a structure for making sure you get your questions answered. It can be sometimes unnerving when you're worried about a medical condition to talk with a medical provider. So if you can just remember those 3 questions, that will help take you a long way. Again, Q&A in the Q&A box if you want to pose a question. And with that, Dr. Pollack, I think we can turn to you.
Donna, thank you so much for the lovely introduction, and thank you to everybody for being here and having me on. It's my pleasure and my honor to get to do this. Real quick, everyone can hear me okay? Yes, okay. Wonderful. I will tell you the double-edged sword of COVID and presentations are, it is so lovely to lower the barrier of entry to get to do these presentations where anyone can join at any time from anywhere, and that's fantastic. The difficult part for both speaker and listener is it's not conducive to interactive talk. So I will tell you, I've been doing this for 2 or 3 years now, and I still don't get used to talking to myself into a camera. I think it's good for people that don't like public speaking because you can just pretend you're talking to a camera, not 100 people. But I do like these talks to be interactive. So I know the chat is a good way to ask questions. And I don't know if people are allowed to speak up or not, but one of my things about talks is I try to give talks like I like to hear them. I have an attention span of a goldfish, so I typically have difficulty listening to anyone speak for more than 10, 15 minutes, and I definitely can't listen to myself talk for longer than 10 to 15 minutes. So I think it's important to keep conversations and talks, especially lectures to people, to under 20 minutes because we really can't listen for longer than that and retain information. And my goals in this kind of 20 minutes of the talk for everybody on here is to come away from this with three major points, three takeaways. Have a better understanding of what exactly is cardiac arrest. We hear this term thrown around all the time in the lay press and in media. Unfortunately, many of us probably know a friend or loved one that suffered from cardiac arrest, but it is used a lot. And I will tell you the term is used incorrectly a lot too. So I do think it is important that we come away from this conversation knowing what does it mean when somebody says, I know someone or somebody I knew or somebody in the news had a cardiac arrest. I think it's important to educate our community on what to do in the setting of a cardiac arrest, because most of these don't happen in the hospital. They happen where you guys are, in the community. So how to identify a cardiac arrest and how you can become part of that chain link of survival, how you can increase the chance of that person surviving. The community is an integral part to that chain. Community is really important in allowing a patient the best chance of survival. And then what we all want to know is, this sounds really scary. Cardiac arrest is scary. How can I lower my own risk of suffering cardiac arrest? So three major things we want to get through as we go through this conversation here. So first and foremost, how common is cardiac arrest? Even take a step back. Question for everyone in the audience is, what's everyone think is the number one killer in the country this year and for many years in the past? It's not COVID. It's not guns. It's not cancer. It's heart disease. Heart disease is the number one killer in the country. And cardiac arrest typically accounts for approximately 300 to 350,000 deaths of Americans a year. It's a big deal. Heart disease is a big deal. We see it every day. It is very prevalent. And cardiac arrest is one of the sequelae. It's one of the events that comes from heart disease. So what we want to start with is the definition, right? So what does cardiac arrest mean when you hear that, whether it's in the news or from a friend or from a provider, healthcare physician? A cardiac arrest simply means the heart has ceased being able to provide adequate blood flow to its organs. At the very highest level, the heart is simply a pump. Its job is to pump blood forward. We as cardiologists think we're important, but we are no different than anybody else, and we are glorified plumbers. We deal with the pumping nature of the heart. So the job of the heart is to pump blood forward, whether it's to the brain, the lungs, the body, pump blood to itself. That pump has three major mechanisms that help the heart do its job. Number one, the pumping mechanism, the actual muscle of the heart that pumps blood forward. Number two, the piping system. There is a piping system that pumps blood to itself. The heart is a muscle, no different than any other muscle, and it requires blood, which carries oxygen, to live. So the heart actually pumps blood to itself via three major pipes, so a piping system. And number three, an electrical system, a wiring that connects all the different chambers in the heart so that pump is firing and pumping in sync with each other. So again, three systems: a pump, piping, and electricity. Cardiac arrest typically deals with malfunction of the pump. The pump is not pumping blood well to the brain. When we stop getting good blood flow to the brain, no more oxygen, we lose consciousness. So the first sign of somebody that is having cardiac arrest is sudden loss of consciousness. So if they're no longer conscious, you cannot wake them up. The first thing we think is the heart pumping blood adequately to the brain? If the pump is not pumping blood adequately to the brain, we have to ask why. And there's two reasons, right? So we said number one in the heart is the pump, number two and three is the piping or the electricity. So either the piping is malfunctioning or the electricity is malfunctioning. One or the other is causing that pump to stop pumping blood forward. 75 to 80% of cardiac arrests are due to the piping in the heart, right? So heart attack. We're going to talk about what a heart attack means, but right now we're just definition of cardiac arrest. So heart attack, artery in the heart blocks off, no blood flow to a section of muscle, heart stops pumping blood well forward, no blood to the brain, cardiac arrest, we lose consciousness. That's the majority of cardiac arrest, and is why there is a misnomer where people that have cardiac arrest have had a heart attack. But not every heart attack causes a cardiac arrest. Most don't in this day and age. And not every cardiac arrest is caused by a heart attack. I know that sounds confusing, but it's important to recognize, because 1/4, 25% of cardiac arrests have nothing to do with heart attacks, have nothing to do with the piping system, yet have everything to do with the electrical system. So that electrical wiring goes haywire, and instead of pulsing at a normal rate, starts pulsing at a very fast rate, usually somewhere in the 200 to 300 times a minute. If that heart, which is supposed to go 60 to 100 beats a minute, suddenly goes 300, 400 times a minute, there's not going to be adequate blood flow to your brain. You lose consciousness. And if it doesn't come back to normal and it continues to go that fast, that also is cardiac arrest. Again, cessation, stopping of blood flow to major vital organs. So what is cardiac arrest? Cardiac arrest is the stopping or cessation of blood flow to vital organs, typically due to either a piping issue where you have a sudden blockage in one of the arteries of the heart, or due to an electrical issue where the wiring in the heart causes the heart to beat fast and irregular. So that's our definition of cardiac arrest. So you're in the community and you see somebody suddenly lose consciousness. What can you do? Well, what the majority of us do is watch, right? We don't do anything for many different reasons. But many of us are worried. We're not ACLS trained. We're not an EMT or paramedic. We're not a doctor. But the things that we do in the community when somebody experiences cardiac arrest is very important. Once you stop getting adequate blood flow to your brain, a clock starts. And the longer it takes to restore adequate blood flow to the brain, the less likely one is to survive. The odds of survival are dismal to begin with cardiac arrest. It is typically less than 10%. 1 in 10 people survive cardiac arrest. To make those odds better, we have to shorten the time where we can get blood flow back to the brain. It's typically 6 minutes. When we get beyond 6 minutes from cardiac arrest, the odds go down quickly. So what can you do? First, identify loss of consciousness. So if somebody loses consciousness, you go up to them, rub their chest, and see if they respond. If they are not responding, 911, right? Somebody should be calling 911. You're identifying someone to call 911. Number 2 is not start CPR, right? Number 2 is an AED. an automated external defibrillator. And thankfully, due to AHA, our cardiology society, and a lot of public service campaigns, there are AEDs everywhere in public spaces. So if you are somewhere in public, at your local church, at your local gym, at a Ravens football game, there should be an AED somewhere. So somebody should be calling 911 and somebody else should be searching for the local AED. The great thing about AEDs is you need zero training in how to use them. You just have to have the courage and willingness to open it up because it will talk you through it, and it is meant to be used by someone with a 4th or 5th grade level of education. So my daughter, who is in 1st grade, should be able to figure it out. You open it up, it will talk you through everything. You don't need to know how to take someone's pulse. You shouldn't even be trying to do that. You should have the AED. There are 2 pads that you put on the person's chest, and it will tell you whether or not that heart is providing adequate blood flow to the brain. Once we do that, we hopefully have 911 on the phone. We have this defibrillator that is telling us what to do. And then we make decisions on whether or not we need to provide chest compressions or push a button that provides electricity to restart the heart. Remember 2 reasons, the piping or the electricity. If the electricity is not working, if we reset the electricity, we can reset and restart the heart so it starts pumping normally again. So again, if you identify somebody that has a loss of consciousness, what are you going to do? Make sure they're actually lost consciousness before you call 911. Try to wake them up. If you can't wake them up, somebody's calling 911. Somebody else is looking for that orange or yellow AED, opening it up and following instructions, waiting for help. Good. Let's go to heart disease, because I think this is important to understand, because this is the major reason to have cardiac arrest. And above and beyond that, it's the #1 killer in this country. So when I say heart disease, when somebody says they have heart disease, what do they mean by that? Well, we talked about the piping system. There are 3 major arteries in the heart that provide blood flow to your heart muscle. And these are no different than water pipes. And as good as many of you probably look, your pipes are as old as you are. So in my 40-year-old pipes don't look like they once did when they were 20. And I don't control my age. I don't control my genes. I don't control what mom and dad gave me in my genetic history. So the makeup of your pipes. And as time progresses, your pipes can get rusty, and rust, right? Crud in water pipes is called atherosclerosis in the arteries, in the pipes of the heart. And that is literally, if you can see my slide, crud that develops in the walls of the heart. This is a lifelong process. It starts when you're born. Again, it is due to age. It is due to genes. And then it is due to many things we as Americans don't do well in this country to ourselves. This does not happen suddenly. You don't get a heart attack today. You develop heart disease, usually starting in your 20s, with mild crud, atherosclerosis plaque, that develops in your heart over time. Heart disease presents in one of 2 ways. If you're lucky, you present with angina. Angina means if you look at a pipe and it has a narrowing in it, more than 70% pinch, and fluid can't get past it fast enough when the other side of the pump needs more fluid, i.e. blood, you will get angina, which is pain, pressure, tightness, discomfort in your chest, typically with exertion. And what happens there is your heart needs more blood flow, and it can't get it fast enough through that pinch. So it's telling the body, hey, I don't like this. So that's #1. Presenting with angina is great because you are identifying that you have heart disease. The second way many people present with heart disease is a heart attack. What is a heart attack? Well, heart attacks start because you have atherosclerosis, plaque, crud in the arterial walls, the piping of the heart, and it's silent. You don't know it's there. And if it's silent and it's unstable, think about an inflamed zit on your face that explodes. That explosion happens in a very small pipe in your artery and suddenly blocks off that artery. And when you get a sudden blockage in your artery, you suddenly get no blood flow past that, and typically in a large section of your heart, and you get an elephant sitting on your chest. That is a heart attack. Now, we said in the beginning, every heart attack does not lead to cardiac arrest. We're very lucky in 2022 to have an amazing healthcare system, amazing medications and interventions. Most do not. But if you have a sudden blockage and it affects a certain space or section of your heart and also affects the electrical system, that can cause cessation or stopping of blood flow to the brain and cardiac arrest. So what we want to do is identify heart disease before it can cause any issues, right? So again, this whole analogy of a pipe, we don't even want to identify it by angina because that means this has been going on for a very long period of time. You have been growing plaque for a while. So at the top there, if you have enough plaque that has grown, blood flow can't get past it and you will have angina. Number two, below that is what happens with a heart attack. You just have a very mild streak of plaque in one of your arteries that you would never know. There are no signs. Stress tests, electrocardiograms, those do not identify these things. And it randomly explodes and blocks off an artery. So we want to prevent this. And if you have some, which many of us do, we want to stabilize where it is so it doesn't explode and block off an artery, so it doesn't progress and narrow an artery to cause angina. So how are we going to do that? Well, first and foremost, we want to practice the healthy 8, right? These are life's essential things that we should all start doing from the very beginning. Number 1, 2, and 3 are the bottom of the iceberg, not the tip of the iceberg. This is the core foundation. And all of us can do this, regardless of socioeconomic status, how much money we have, where we are in life, what we can do. We just have to start doing that kind of behavior from the beginning. And I say that with the knowledge that it is really, really hard. We as humans are not meant to live in a culture of abundance, where I can get a cheeseburger at McDonald's for $4 down the street in a blink of an eye. We are meant to live on the plane where food is scarce 10,000 years ago, where I don't know where I'm going to get my next meal. So our genetics are meant to retain calories. It's why we have an obesity epidemic, not only in this country, but in the world, because we are not meant to be able to eat food whenever we want. We are constantly hungry because our body is trying to survive, and yet that is working against us. So it is very hard to stay a healthy weight because we are fighting against thousands of years of genes telling us to eat better. And the food that we have that tastes good is not good for us. But trying to eat an improved diet, trying to exercise daily is unbelievably important. And it doesn't matter the age you are. I hear this every day. I have knee pain. I don't have access to a gym. I can't walk. I can't exercise. There's no way I can lose weight. And what I tell every one of my patients, including myself, is unfortunately, exercise is not how you lose weight. I say it again. Exercise is not how you lose weight. Actually, if you start a vigorous exercise regimen, you will probably gain weight because you're going to be hungrier. Your body thinks you need more calories. And if you're older than the age of 25, the chance of you being able to exercise away your extra calories is gone, okay? Unless you're a professional athlete. So exercise is good for you. It is important, but it is more mentally healthy than it is physically healthy. There are obviously physical benefits to exercise as well, but losing weight is all caloric intake. Again, I hear it every day. I say it to myself, I can't lose weight, but I haven't really eaten much. We all have to be more honest with ourselves. What are the calories that we are putting in our body every day in and day out? And not one of us, including myself, is honest about it. I forget about those 3 Oreos I ate last night. I forget about the candy bar or the York peppermint patties that are sitting on my desk. So we just have to eat less and be conscious about it and recognize that we all are human and we all fail. And as we're going to fail, we're not going to eat perfect all the time. And I'm a big fan of the 70-30 rule or the 80-20 rule. Try to eat healthy the majority of the time, but you want pizza from Pepe's or Maria's, you want a bacon cheeseburger from Five Guys, that's okay. You're not going to die from a heart attack from that. You'd actually be healthier, but don't do it every day. Exercise is important. The AHA, our cardiology society, says to do it 30 minutes a day, 5 days a week. I think that's baloney. I think we should move every single day. I never prescribe a certain exercise because we are all different. That's what makes humans amazing. So find the exercise that you love. And anybody can exercise. For my 90-year-olds that are frail and have trouble walking around, exercise for them is as simple as getting in and out of a chair 10 times over 30 minutes. For my young 40-year-olds, exercise is a little more vigorous. So going on a run 30 minutes a day, going on a brisk walk counts. But work is not exercise. I don't care how many steps you get. That is not exercise. For my golfers, 18 holes is not exercise. Tennis players, or maybe exercise, but still, you have to do exercise above and beyond. And I know all of us are busy. I know we don't have time to do it, but we have to invest in ourselves before we can invest in others. So if we're not taking care of ourselves first, then we can't take care of anything else in life. So we have to make the time to take care of ourselves. So that's the holistic approach to your health. And I can't tell you how important that is. Everything else I do for patients, it matters nothing if we can't improve holistically your approach to your own health. LDL is my biggest enemy. It's my enemy number one. LDL is the biggest driver. It is the cause of atherosclerosis. And the treatment for LDL, if you have elevated LDL, which means if you're an American over the age of 30, you probably do, are statins. And this isn't a talk on statins. I'm happy to give that another time because I love that medication and they should be in the water. But I know many of you are saying in your heads, no, they're not. They're the devil. I have side effects from them. But again, we want our LDL controlled. We want to make sure our blood pressure is controlled. Blood pressure, like heart disease, is the silent killer. Doc, I feel fine. My blood pressure is fine. Okay, when's the last time you check it? I don't check it. I feel fine. That's not the case, right? You're not going to know your blood pressure is elevated. High blood pressure doesn't cause symptoms until you're above about 200 over 100. So running 150 or 160, you're never going to feel that until it's too late. So whether you're 35 or 85, everybody should be checking their blood pressure, not at the doctor's office. I actually don't like that we check blood pressure at doctor's offices because it's never correct. It's either too high or too low. What I want to know is what is your blood pressure in your own environment at home, when you're at rest, when you're sitting. So again, I think everybody should invest in a blood pressure cuff, the automatic one that goes on your bicep. Really nice investment that you can have for the rest of your life, and they all are accurate. We want to make sure we don't have diabetes. That's something with your primary care to screen for diabetes at least once a year. If you're one out of 5 or 1 out of 10 Americans that are still smoking, I think stopping smoking versus losing weight are equally as hard. And unfortunately, my obese patients that are smoking, man, that's even harder. But stopping smoking is so important. And I also, just like with losing weight, know how hard it is to stop smoking. And then we added an eighth, right? An eighth one here is getting good sleep. So there's a lot of benefit to good sleep hygiene, getting your 7 to 8 hours of good restful sleep at night, not using that iPhone or Android for the hour before sleep, doing things that calm the mind and calm the body before we go to bed is extremely important. So we do all these things together. We're doing them right. Okay, I'm not going to get heart disease. Unfortunately, that's wrong. Okay, heart disease, especially in 20% of Americans, even if you're doing all 8 of these perfectly, is still present. Because what do we not control? We don't control our age and we don't control our genes. Oh my gosh, Doc, so how do I know? Am I going to die from a cardiac arrest? How do I know if I have heart disease? Well, we have a great screening test called a coronary artery calcium score. This has been around for 20 years. And unfortunately, it is not a guideline-based screening test for every patient. We screen for breast cancer with mammograms. We screen for colon cancer with colonoscopies, yet these are the 5 and 7 killer in the country. We do not screen for the number 1 killer in the country, heart disease. Why is that? Again, that's a whole nother talk. But remember this term, a heart score, coronary artery calcium score. It is not for everyone, okay? This is not going to tell you if you have a blockage. This is not the way to track your heart disease. This is a test that identifies the presence of asymptomatic heart disease, meaning you have plaque in your arteries, yet it is causing you no issues right now, and you would never know it. And if I can identify plaque early in you, I can't make it go away. It's there. But if I can stabilize it so it doesn't progress, if I can stabilize it so it doesn't rupture, I've just saved your life. You've just saved your life. And there's lots of things that we can do to do that. So identification of this early, I'm a big believer that around the age of 40, we should start screening for this, especially in patients with elevated risk for heart disease, which, by the way, is every single one of us because we're Americans. So the calcium score is a very important way to look for this. It's an easy test. It is a CAT scan of your chest. It is low radiation, typically no different than a transatlantic flight. The unfortunate part of it is insurance does not cover it, so it is out of pocket and typically costs $100 to $125, which I would argue is a well worth investment in your health to identify something that kills the majority of Americans. The nice thing about this is this test is direct to consumer. You do not even need a doctor's order for it. So you can go to any advanced radiology and get it yourself if you have the $100. But it's nice to have a doc order it for you so that you can help interpret it. Someone can help interpret it. All right, so what are our key takeaways? What is cardiac arrest? We went over this in the beginning, and again, to summarize, this is the cessation or stopping of blood flow to vital organs and is due to either a sudden blockage in one of the arteries of the heart or due to malfunction in the electrical system. Number 2, how are we going to identify this? This is first and foremost due to loss of consciousness. Make sure they are actually lost consciousness. Call 911 and get the AED and put the pads on the patient. Put the pads on the patient. What is heart disease? Heart disease is the development of plaque in the arteries of the heart due to genes, age, and these 8 things over time. How can I identify it? If I haven't already identified it, think about a calcium score. And that is cardiac arrest in 20 minutes or less. So I know we have the chat open. I can't see the chat, so I'm assuming Donna will read these questions and I can answer any questions that the group has.
I will bring the questions to you. Thank you. That means I'm thinking I'm sure glad I did my 30-minute walk already today, and I need to make sure I do it every day. Thank you so much. So informative and really concise. I've got a comment here that I want to share first before we get to the questions, and there are some great questions. It says, and I won't identify the writer, but wow, I'm certainly fortunate to be amongst the 10% survivors. I'm also fortunate that I didn't lose consciousness immediately. I got lightheaded. I called 911. They got there quickly. They gave me the paddles. My heart was going at 220. So, yeah, that's crazy.
For the commenter that made that is wow. Thank you for sharing. And I think that's an important point. Is you are right. Not all cardiac arrest is sudden loss of consciousness, and you were smart enough to call and get help. And what you had was the electrical problem, right? So sudden electricity causing the heart to go very fast. And usually if we can get to you quick enough and put those pads on and reset your heart, we can get blood flow going back to your brain and avoid the last set of what happens with cardiac arrest, which is loss of consciousness.
And let me follow up on that. Is that the kind of scenario where someone who's experienced that might ultimately get a defibrillator?
Yeah, Donna, that's a great question. So first, what is a defibrillator? So a defibrillator is a small device that goes under the skin with wiring that connects the top to the bottom of the heart that watches the heart electrical system 24/7, 365 days a year. And if that happens again, that electrical abnormality can provide that electrical shock immediately instead of waiting for people to put pads on you. And the answer is no. Just everyone that has cardiac arrest does not need a defibrillator. That's a case by case decision depending on many different things that once we're in the hospital we sort through.
Great. So one of the first questions that came in was, what's the latest treatment for AFib? Maybe we first define AFib and then answer that. Okay.
Yeah, no, good question. That's a talk in itself. Just atrial fibrillation and what it is, what it means, what do we do about it, what are the risks for it, how do we get it? Again, AFib is the electrical system of the heart, deals with increased electrical impulses from the top of the heart or the atrium. When we're talking about cardiac arrest, that's increased electrical impulses from the bottom. So, that kind of question is something that we could talk about for an hour because there's lots of things to talk about with AFib. But very simply and high level, AFib is typically due to chronic stress on the heart, not emotional stress, the physical. And the prevention of atrial fibrillation is the same as the prevention of coronary disease. Maintaining a healthy weight, exercising, and eating healthy. We all wish we had some magic pill or magic procedure to stop AFib or stop heart disease. But the newest and the greatest to stop AFib is getting to a healthy weight and maintaining it, exercising every single day, and eating well. And I can't tell you if we could get America to do that, our healthcare resource utilization would go down by 80%.
Wow. So you spoke about how important it is if you see someone who's lost consciousness, call 911, get the AED. Someone asks here, I think importantly, do we assume immediately that it's related to the heart if you lose consciousness, or might it be something else? So maybe you wouldn't take those steps.
Yeah, great question. We have no idea, right? You're not going to know immediately. And even me as a cardiologist in the field, right? And the most common reason I get called to help in the field is loss of consciousness. I don't know what's going on. I follow the same steps. Somebody call 911. Somebody get the AED. I'm trained so I can check for a pulse. So I don't technically need the pads on there, but I like them. But above and beyond that, the reasons for loss of consciousness are very long. But everybody that loses consciousness, we assume is having a cardiac arrest because that is the life-threatening issue, right? So we want to make sure we're treating that because we don't want to miss that. But there are 50 different reasons for someone to lose consciousness. And I will tell you 9 out of 10 or 9.5 out of 10 times for somebody to lose consciousness in the field is due to vasovagal syncope. What does that mean? Your blood pressure suddenly drops because your arteries dilate. Blood goes away from your head. You get dizzy and lightheaded and lose consciousness. That is not cardiac arrest. That is common. 1 out of 2 people will have one of those events at some point in their life. And I have almost every time when I'm asked to help in the community, it is due to that. And what do? What should you do? Somebody's starting to get dizzy or lightheaded. Do you feel dizzy or lightheaded? Everybody wants to fight it. Everyone wants to try to not pass out because it's embarrassing, right? No. What's embarrassing is losing consciousness and head goes in the soup, right? So get on the ground. I put the patient on the ground and I put their feet above their head, okay? And typically when I do that, it restores consciousness or they don't lose consciousness. And if that happens, I know we're okay, right? You can't have a cardiac arrest if you're talking to me because you have blood to your brain, right? So somebody feeling lightheaded or dizzy, you're feeling lightheaded or dizzy, go to ground, get on the ground, put your feet above your head. Blood will go back to your brain. You will feel better.
That is great information. And I want to follow up on something you said from the one time I took a first aid class. If you come across someone who you think may be having a heart issue and you're kind of taking charge, you say you and point to someone, call 911. You look for an AED. Otherwise, everybody thinks somebody else is doing it, right? And you want to make sure that it happens. So
Yeah, Donna, that's a great point. Usually in these situations, it's a bunch of chickens with their head cut off. So somebody needs to be the leader, and that leader needs to literally grab. I actually like to put my hand on the person, say, call 911. All right.
mhm,
Yep, that's
great,
right.
great. Oh, question about the AEDs. Are there affordable AED devices for your home or
Yeah.
maybe even to have in your car?
That's such a good question. There's never been a study to show benefit of home AEDs. One would think, oh my gosh, wouldn't that be great if it happens, my loved one can put it on me. Although this sounds scary, it is a very, very low risk. 350,000 people out of 300 million, it's very low. So I actually don't recommend that. I don't think that is a wise investment. Even my patients that are at highest risk for sudden cardiac death, I'm not having them put an AED in their house. We're putting a defibrillator in them. So no, I don't think that is wise. You can do it. They will sell it to you, but I don't think that's worth your money.
Right. Here's a really great question, and I even asked for clarification when it came in. Do all heart attacks cause the intense pain, the elephant sitting on the chest that you mentioned? Or is it true, as I've heard, that there are some medical conditions such as diabetes where the person might experience less intense pain? And I guess meaning mistake what's happening for something else.
Yeah, very informed group here, and a fantastic question. You are correct. Not we learn this when you get out of medical school. Not everyone. It's called not everyone reads from the textbook, right? So textbook says elephant on chest, crushing pain, impending sense of doom. Not everyone gets that, and we all experience pain differently, right? That's the nature of humanity. And you are right, diabetes can blunt pain experience. So it's all different. But the majority of people experiencing sudden cessation of blood flow to the heart muscle will have some sort of sensation in the chest, typically as a pressure or tightness. Nobody says pain, it's a tightness. Sometimes it can radiate down the arm. Sometimes it can go to the jaw. And again, there is, we as humans do have an alarm system. And when that alarm system is going off in your brain and you're having some sort of symptom, the biggest thing is do not ignore it. Right? So we see that way too often. And we all know those stories. So don't ignore it. And please don't drive yourself to the emergency room. And we all know those stories. Call 911. Just call the ambulance. Don't drive to the fire department. Stop where you are. Call 911.
Great question here. Well, they're all good questions. How often should we check blood pressure at home?
Yeah, that's a fantastic question. That's a specific case by case. So we'll take the three cases. So a young, healthy person with no medical problems between the age of 30 and 60, right? Once a quarter, once a semester, once every few months. And do it correctly, right? So briefly, you sit down at rest, not after you've run 4 miles or not after your wife or husband or significant other have yelled at you. You're at rest and you're sitting and your feet are on the ground. You put it on the bicep, not the wrist. The wrist doesn't work, those wrist cuffs, the bicep. And you take it 3 times over 5 minutes and you take the lowest number. And typically it's the third time, which is going to be the lowest. So again, no medical problems and healthy, once or twice a year, right? And make sure you don't have high numbers. If you get a high number, then you're doing it more frequently. For my middle risk patients that have other medical problems, they're between the age of 40 and 80, they have diabetes or high cholesterol, maybe once a month, twice a month at rest. And pretty much the same for my hypertensive patients that are on blood pressure medications. If you're on stable blood pressure medications and there have been no changes, I typically tell my patients once a month or twice a month. If I'm making changes or I'm asking you what your blood pressure is, then it's once or twice a week. The daily, multiple times a day, you come into the doctor's office with a log of thousands of blood pressure medications in your Excel doc. No, please don't do that. Again, it's really no more than once or twice a week at most.
How did you know I was doing that? Okay. All right. So you've lit a firestorm here with the test, and somebody asked, what's the name of it? Coronary artery calcium score.
Yep.
Right?
So
So then
coronary calcium score, the score part is missing on this slide. Coronary artery calcium score, CAC score, heart score, any of those names work. Now,
there are,
again, yeah, and remember, this is not for everybody, right? If you have heart disease, no. If you're older than a certain age, what is that age? I don't ever age discriminate. But again, somewhere between the 70 and 80 range, you don't need this because you probably have heart disease. We're not doing it for tracking purposes. It's typically for the age range of 40 to 70 where we don't know you have heart disease.
well, there's some policy questions here, and I, don't want to put you on the spot, but several people are saying, why isn't this part of a regular regimen? And, if heart disease is the number one killer, what's the delay here, and why aren't insurance companies paying for
Yeah,
this?
good. Yeah, I mean, that's such a good question. And I'm not a policy expert, so I can't answer that. I can tell you that this isn't a screen for all. So that's the first issue, is policy typically simple is better. So colonoscopy for all, that's easier to do. Calcium score for all doesn't work for the reasons I kind of just said. If you have heart disease, it doesn't work. If you're over the certain age, it doesn't work. If it's not going to change management, it doesn't work. So you've just taken off a swath of the population. So you can't screen everybody, number one. Number two, there are inherent problems with screening programs. That's a whole talk in itself. Is MIA actually going to change outcomes, change things for the whole population? And there's not good data that this test changes things for the whole population. I argue, and many of experts will argue, it changes individual outcomes. So that's a different conversation. And again, it is indicated for the individual screening. So I think that's why, in a nutshell. I can't, if I'm the Surgeon General, I can't say everybody 40 to 70 gets a calcium score. 10% of people with calcium score have incidental findings. We see the lungs too. So then you have 10% of the population now has to get repeat calcium. There's lots of problems. But education for everybody to talk about this test with your primary care physician is very important to consider this if you're in that 40 to 70 age range.
Okay, someone said, can you elaborate on what do the scores look like? What's a bad score? What's a good score?
I love that question. It's my biggest pet peeve, actually, with the calcium score. I fight with radiology. I don't fight. I'm in an ongoing discussion with our radiologists because they will give you a score and they will tell you each artery. I have patients will come in with that score highlighted. My Widowmaker has 400 calcium. I wish, and if it was up to me and I was the policymaker, it should be a binary test, meaning you either have coronary calcium or you don't, because coronary calcium is only an indicator of a systemic whole body process that you have plaque. It does not tell me how much. It does not tell me where. It does not tell me your risk of heart attack. So again, that's if you come to me and I do this consult a lot in my office. That's the first thing I do with the patient is tell you this is actually good news. You don't have a blockage. We just know you have something that you've had for a very long time. It is there. It's not only in your heart, it's in your neck and your brain and your legs. It's everywhere, right? Your pipes are 70 years old. And now we can do things to staunch that progression. So I don't care what the score is. There's no such thing as a bad score. There is a good score, which is 0, meaning you probably don't have any plaque, which is fantastic. Anything above 0 means you have plaque, and it really should only be 0 or above 0.
The questions are coming in fast and furious. We're not going to be able to get to all of these. I'm trying to get to some that we may not have addressed at all. How do we know the difference between heartburn and heart attack?
No, such a good question. That's tough, right? So, and heart pain or angina can mimic reflux, and reflux gastric pain can mimic chest pain. Again, some of the classic teaching, right? So reflux is after eating. Reflux is when you're trying to lay down at night. Reflux is typically that burning sensation in the middle of your chest. And angina is more exertional. Angina is with exertion. Remember that pipe analogy. You have a narrowing in your pipe. Blood can't get to the heart muscle fast enough when it needs more blood flow with exertion, walking upstairs, walking up a hill, walking to your mailbox, and you get that tightness in your chest that goes away when you rest. But it's a Venn diagram, right? So there's a lot that exists in the middle. And that's the role of the primary care physician or your cardiologist to help you figure out what is what.
Dr. Pollack, there are several questions that we won't be able to get to, and I'm wondering if we can answer those after. We can put them up on the site and I'll explain. There's
Happy
only a
to.
few. But
Yep.
here's one that says, um, my husband had dilated cardiomyopathy with a low EF. I don't know what the EF means, but maybe you can explain. He died from sudden cardiac arrest. Should all cardiomyopathy patients have an implantable defibrillator?
Yeah, that's such a wonderful question, and I'm so sorry to hear that about your loved one. Again, that is a whole nother talk. That's an hour talk about a cardiomyopathy, which means a weakened heart. And from a high level, a weakened heart gets dilated. It expands, and what happens when it expands? The electrical system expands, and those wires get frayed, and they are more likely to fire really fast and cause that fast heart rate from the bottom of the heart. So patients with cardiomyopathy or weakened hearts are at higher risk than everyone else of sudden cardiac death from electrical abnormality, not a heart attack. Does everybody with a weakened heart get a defibrillator? No. No. That's why you go to a heart failure specialist, because there's amazing medications we have that can make a cardiomyopathy get better, where you don't need a defibrillator. So that we can actually cure or cause remission of cardiomyopathy in 2022. And we do that every day here in our clinic, right here where I'm sitting. Not everybody needs a defibrillator.
This has been amazing, and there are several comments to that effect for you, that your answers have been so good and the information has been so good. Let's go to the next slide. I think that we will keep the questions that have come in that we're not able to address at all. Some did overlap, and there were several that were very similar. So I want to tell the group, it was mentioned up front, but in case you did not hear it, this webinar has been recorded and will be available online in about 48 hours at www.ums.org/Let's Talk, the name of the series. And there you can see all of the other presentations as well that we've done over the past almost 2 years now that are already up. We will also take a look at these questions and at some point be able to, with Dr. Pollack's assistance, put up additional answers to the ones that we didn't get to, but we did get to most of them. Next slide. As I mentioned, Let's Talk is a series, and it's a monthly series, normally on the third Wednesday in every month. November, we'll go back to that third Wednesday. And next month is Diabetes Awareness Month, and that will be the topic for the next time. Let me, on behalf of all of the listeners, and we did have quite a few on today, thank you, Dr. Pollack, for a very, very folksy talk, if you will. That's what we do. We talk to community, and very clear and very cogent and very, very complete talk and answers to the questions that so many people pose. Thank you all for joining us as well today. We'll see you next month, and really do feel free to go to ums.org/Let's Talk for more information. Thank you, everyone. Have a great day.
Thank you, Donna. Thank you, everybody.